So thank you so much. This amazing panel is going to bring their skills and expertise together to talk about their part in interoperability. Last night, I was sitting with an amazing past colleague, which she pulled together a few statements for me. I know we all know what interoperability is, but I'm just going to kind of read them because I don't have it memorized, just to kind of set the platform. And the industry has gone through a lot with the definition and lessons learned on the different standards on how to connect. Remember when ONC was formed 20 years ago and how we tried to connect technologies to improve adoption, the successes and the failures, especially surrounding RHIO, which are the regional health centers. We had minimal standards, hopefully that's changing today, but we had a huge appetite for it. And industry, it's incredible how much we've matured with lots of flavors and how we share information, which is allowing new technologies to thrive. We have choices with FHIR, API, and still the good old HL7. We have so many options how to connect, and we demand that we do connect. I am thrilled and excited. This amazing panel has been put together for all of you and on a timely manner. We need this now. John Backus totally gave a great introduction into interoperability. So we're going to start and kick this off with CalHIPSO, David Ford, and basically they're going to do all the work for me. They're going to give some case studies, and it'll be interesting to hear from the audience at the end, maybe some questions that you might have.
When I signed up to do this presentation, so we're each going to do presentations, I'm going to take something that normally I present for 45 minutes and condense it into 7. So to say, it's going to be the rock skipping across the pond here. There we go. We gave a brief introduction, but because CalHIPSO traditionally actually has not done a lot of work in Los Angeles, we have a sister organization here in town called High Tech LA. So if you're familiar with them, we've been like High Tech LA just everywhere else. We were originally formed to be a regional extension center designated by the federal government 10 years ago, a joint effort of the California Primary Care Association, the California Medical Association, and the California Association of Public Hospitals and Health Systems. Over 10 years, CalHIPSO served about 15,000 unique safety net providers, predominantly in community health centers, small practices, public and critical access hospitals, and a growing number actually of dentists. All of which have, sort of collectively, we term the safety net. And as far as this conversation, when we're talking about addressing disparities in healthcare, myself, High Tech LA, co-rec in Orange County, we've served the providers who serve the vast majority of Medi-Cal and uninsured patients in this state. And since I have to be very brief here, I'm just going to give you guys a little bit of a way, I think, to think about where we are in health IT. And I like to talk about this as we've been on 2 parallel tracks in healthcare. When it came to health IT 10 years ago, the federal government, gave us the Stimulus Act and meaningful use. And we really, when it came down to it, they were only really driving towards one thing, which was EHR adoption, right? And you look at a lot of the public pronouncements, there were just how many physicians have adopted an EHR. And if that was your goal, then it worked, right? EHR adoption rates, as you see in the slide up on the screen, went from about the high teens, low 20s to where they sit today nationally, somewhere about the mid 80s to low 90s, depending on whose numbers you use and how you determine which providers you're counting. But I think we all know we only actually did half the work, right? Because we drove to adopt, get to meaningful use. But we've left providers short of a lot of things that really they should be doing with their EHRs. And a lot of providers, even who adopted an EHR, still aren't doing the things that John Backus was just talking about, care coordination, data exchange, or that big, ugly, scary term, provider payment reform. Plus the fact that the Stimulus Act, I think we all know, left out a lot of people. dentists who don't do more than 30% Medi-Cal, which, by the way, I've looked at the numbers, is just about all of them. Behavioral health providers, for example. We completely passed them over. I know many people have tried, and I'll get back to them in a moment. And we were doing the same thing in the insurance world. We did the Affordable Care Act, and what we were driving towards is getting people covered. And there again, when you look at when people assess, like the Kaiser Family Foundation did in this slide, was the Affordable Care Act successful? People say, yes, absolutely successful. Look at how much the uninsured rate dropped. And don't get me wrong, that's an important thing to drive towards. But there again, I think we know that's really only getting us halfway to where we need to go. And the really hard work of healthcare reform is actually still ongoing, and in many ways is just getting started. In delivery system reform, provider payment changes, and then of course, trying to get enough providers into the pipeline to help all those people be seen. So the question becomes, where do we go now? And right now, because we've had these two parallel tracks, we're trying to solve several problems at once. And we are trying to encourage providers to use their IT for all the things I discussed before for their intended purposes, trying to bring more providers into the system, and try to bring new resources into the safety net to help drive delivery system reform. So I can't solve all of that in the next, now I think 4 minutes, but I'll give you a couple things that we are working on that I think are steps in the right direction. So one of them that was referenced, and hopefully will be an actual approved and functioning program here very soon, is what we're now calling CalHOP, the California HIE Onboarding Program. Now, as was referenced in my introduction, myself, Claudia and I were kind of joined at the hip on this one. CMA, Blue Shield, a coalition of about 15 other groups, lobbied the legislature last year to put up $5 million as a match to draw down $45 million in 90-10 funding to help providers onboard onto health information exchanges. So we're not building HIEs with this money. What this money is to help defray those, what can be sometimes substantial upfront costs to providers to actually connect to the system and to begin using it. Also to provide some technical assistance to providers to utilize it. Now, why this matters, especially in the safety net, is because it is 90-10 funding. If you're familiar with our 90-10 funding, that has to be targeted to Medi-Cal EHR incentive program eligible providers. So this is going to be heavily about connecting Medicaid providers to HIEs. And then also, since there was a reference to opioids earlier and the public health crisis that we're dealing with nationally, part of the funding in this project too is to help health information exchanges connect to the new API that's been published by the California Department of Justice for the Cures database. So hopefully we will take a big swing at opioids in this one by getting the providers on the HIEs connected to Cures, which should make Cures information flow a lot more freely. Timeline, as I say, I had hoped by the point I was giving this presentation, this project would be up and running. When you're dealing with negotiations between the state of California and the federal government, which you might have heard can be a little tense at the moment. So we're not quite there yet. As of the last time I talked to the State Department of Healthcare Services about this, their target currently is July 1. And then I wanted to bring this up too, because once this project is approved by the federal government, we are going to have to move really, really fast. The problem is that as we've lost some time on the front end of this project, we are not gaining time at the back end of this project, because the HITECH Act goes away September 30th, 2021, or at least all the funding behind it does. So that part, we're losing time this way and we're not gaining any here. So if we start July of this year, it'll give us about 27 months to spend that money and get all the targeted providers on board. One other thing, I do not have a whole lot of details on this. I have dug as much as I can, but back in the fall, President Trump signed the Support Act, which was a federal bill on opioid legislation, buried way down deep in that legislation. I think a lot of people don't even realize this was here, is an opportunity to actually pay meaningful use type incentives to behavioral health providers. The way that this is set up is it's not quite meaningful use for behavioral health, as some people have described it. What it is basically in the law, there's a list of things that the Center for Medicare and Medicaid Innovation is asked by the Congress to work on. There were 24 of them in law. This added a 25th, which was to approve pilot projects to pay meaningful use type incentives for behavioral health. CMMI to date has not published a lot of information about how they expect this to work, but obviously could be hugely important because that's a whole universe of providers that I know all of us have been trying to get to for years. We've never quite gotten there. And then finally, because you gave me the stage, I get to brag on my own organization for a minute. About 10 days ago, actually, our organization had our conference, and we announced a new partnership that we think will bring a lot of resources into the safety net. Some of you may be familiar with the organization Aledade, which was started by former staff from the Office of the National Coordinator for Health IT. But they've been going across the country helping small practices and FQHCs organize into ACOs and enter into the world of value-based care. Like everyone else who is not currently doing business in California, they wanted to get into California. And because they're former O&C staff, they sought us out as the Regional Extension Center. And we actually formed a three-way partnership, Aledade, us, and the California Medical Association. And so we will be working collectively to recruit small practice physicians in particular into the world of value-based care, organizing them into ACOs, and hopefully bringing just a new level of attention to that world of providers. So that's my very quick overview, and I will pass off to who's next.
Thank you.
So lanes and interoperability, HIE, and addressing the health disparities. I think we all kind of agree that HIEs can play a major role in addressing the health disparities. At Lanes, we are developing solutions for that, and we have, before I talk about the use cases that leveraging Lanes clinical data repository and the solutions that we offer specific to chronic disease management and opioid crisis and social determinants of health, I want to talk about a little bit about the current environment at the healthcare organizations. The recent need and demand for organizations to know what's going on with their patients outside of the clinic walls. That's something that's new. That's really the shift towards the reimbursement and incentive plans that are in managed care services now pushing to the providers has really created this demand for the providers to seek data from outside of their clinics. So, but that also has created a challenge for the providers. So now they're under pressure to see a large, more patients in a day. They're expected to deliver quality care in a short amount of time, consume a lot of information, digest a lot of information, and then interact with the patient and keep them healthy. So that's a lot of pressure for these providers. And this tsunami of data that's being thrown at them, both from their own internal system, the EHR systems, and from outside, whether it's the HIE that they're connected or the national HIEs, have really created challenge for them. So we are kind of sensitive to that, and we at Lanes, we are trying to provide technology and solutions that addresses the providers' burnout, clinicians' burnout. So one of the things that we are doing, and it's not really unique to Lanes, but it is unique to some of the solutions that we are delivering in terms of providing a bite-sized information that are actionable, information that they can quickly absorb and act on So an example of that is the clinical information at a glance. It's a truncated patient profile, critical information that they can quickly look at and address the patient needs. Or another solution that we are providing is population health reports, alerts that enables not necessarily the physician itself, but the care team, somebody in their organization, to intervene at the right time, mostly during the transition of care, where that's usually where the gaps are, and be more proactive and informed when they're contacting the patients. At the same time, we want these solutions to be patient-centric if we want to get the desired clinical outcomes. So, so our solutions is basically appropriate. It's kind of connecting the patient to the appropriate resources in the care continuum, and the information kind of follows the patient during the care journey from one provider to another, which is basically what we're trying to do, is facilitate this preventive care that has an impact on both the cost and the metrics, the outcome metrics. So that's kind of the environment and what we are trying to match and meet the provider needs. With respect to managing chronic diseases, one of the services that we are offering is event notification service, notification to the care team that have high risk, that are identified those as a high risk patients that are have chronic diseases, comorbidities, and for the care team to follow up with the right information, with the actionable information. These are risk stratification kind of notifications or alerts that can be customized based on the patient profile, patient risk factors, and most importantly, what's going to be sent to the care team, what type of information. Typically, it's a discharge summary from hospitals, but now we are kind of moving into consult from a specialist, consult notes from a specialist, and other provider notes. And then, of course, these are this type of alerts support the transition of care visits, which has some revenue streams to that, and it supports it's aligned with the quality improvement programs as well as the HIMSS metrics. So, from business side is also favorable for the practices. With respect to opioid crisis, which is kind of is a crisis in our region as well. And then when the patients are registered at the clinic or at the hospital and they're connected to our lanes, they get connected to these database that the providers, the prescribing provider can see the important information, the information that is available on the opioid, whatever has been prescribed previously for that patient in the state of California. So this is kind of pushed into the workflow of the clinicians and with the important information so they can make informed and sound decisions. Another service, and we're kind of short on time here, but I'm going to go through this quickly. Social determinants of health, and it was discussed at the earlier panel here, is a major issue for healthcare providers. I think John Backus said it well, that he said that social determinants is a predictive on the health outcomes, and I believe that. And so healthcare organizations now becoming to realization of how to deal with that is kind of an emerging thing for the healthcare organizations. And there was a stats from American Medical Association that the socioeconomic factors are responsible for 40% of the patient health. That's a large percentage that needs to be addressed. And for the healthcare organizations that they want to bend the cost curve related to this. So what the data also shows is that many of these individuals, patients, have the following social determinants. If they're homeless or housing insecure, they have some sort of a mental behavioral health issues and alcohol and substance use disorders. They're also taking a lot of wait time at the EDs, and they're disjointed from their either primary care providers, care teams, and care management in general, and drive up the ED wait times, as I mentioned. And to address that, what we are doing is to, first of all, identify, real identification of these type of patients that persistently are in crisis, and send a notification to the care team to follow up with a patient to bring them into the stable condition so they don't have to go to the do the ED visits. We facilitate linking these patients to their care teams, and then in an attempt to reduce those ED visits and the ED wait time. We also have connecting them to the community resources, such as shelter, behavioral health counseling, as well as social services. Lanes, by the way, we are collecting behavioral health data. We are connected to the Department of Mental Health, the County Department of Mental Health currently, and receiving data from County Department of Mental Health, and we are in discussions or implementation phase with major mental health providers in LA County. We have a care collaboration platform that is a multi-tenant for real-time care collaboration between the providers, whether it's care providers or there's also community resources. So it's kind of a warm handoff of a patient from a hospital to a shelter or social services or behavioral health counseling, depending on what it is. So they're all on the same platform, and they be able to hand it over, get acknowledgement. If they don't have a capacity, they will let them know, okay, there's no capacity here, try somebody else. So it's kind of a connecting really the community together, and this is kind of our attempt in, one aspect of our attempt in terms of addressing the social determinants of health. We are also working with the whole person care program in LA County. We're working with the housing, LA Housing Authority or Homeless Authority, and coordinating our efforts, working with 211 LA in LA County to collect data related to social determinants and share it with our participants. David mentioned about, that's the wrong key. David mentioned about the CalHIPSO program. It's a grant program that, thank you. So it's a grant funding program that David did a great job in facilitating that. It's a $50 million CMS grant, connect medical providers to HIEs. Lanes will be authorized to distribute this money to fund to anywhere from small doctor offices, $15,000 to cover their costs of integrating with Lanes, to hospitals over about $100,000 they can receive to cover that cost. Lanes is waiving this subscription fee for the first year in order to encourage these providers to jump in. As David mentioned, the timing is very short. It's about, when David talked about this timeline, and now they say it's July. It was supposed to be February, and now it's moved on to July. So we are hoping we would catch this before 2021, right, Claudia? Yeah, so I think I'm getting over my time, so thanks very much for your attention.
Hi, everyone. I know it's before lunch, so hang in there. So I wanted to talk to you today about the Community Clinic Association of LA County. That's where I'm from. I'm the director of HIT there. As you know, I've been there for 6 years. And I've seen a lot of transitioning that has happened from health centers not being on an electronic health records to adopting electronic health records, to now having data analytics tools, and to now, SDOH data being able to be collected and actionable in our electronic health records. So it's been really nice to see the evolution of EHRs in the community clinic world. How does this thing go? Okay. Okay, there we go. So the Community Clinic Association in LA County, we have 65 nonprofit community health centers. And if you see the geographic region on the left, there are many different spas that we have our health centers in. And the health centers actually expand outside of LA County. They go into the Inland Empire and Orange County. And just to kind of give you an example of how large LA County is when it comes to community clinics, a lot of other associations like ours have about 10 health centers. So we are huge. The patients we serve is 1.6 million patients per year. Our demographics are the uninsured, underinsured, low income, and the homeless patients. And the electronic health records we have, as you can imagine, we have 65 health centers, and they all have, you know, their own decisions on what EHRs they want to use. We have 13 different types of health centers. So when it comes to interoperability, imagine like integrating 13 different electronic health records. The good thing is there are 3 that are used the most, which is eClinicalWorks. We have 25 health centers on eClinicalWorks. NextGen, we have 19, and Epic, we have 8. We do have some of our clinics here, actually. We have the Children's Clinic sitting over there, and we have Mission City right over here, so thank you. The services we provide are primary care healthcare, including medical, dental, mental health services, and we also have pharmacy dispensaries. Actually, it's great to have John Backus here and having Lanes here and representing LA County, because we all are partners and we all work very closely together. Many of our patients are managed care patients from LA Care. And all of our uninsured patients get their specialty care through DHS. Next slide. So we're the Association for California. We have other associations that we work with, which is the California Primary Care Association, and they basically handle any issues that are statewide. Anything that needs advocacy that's affecting us is where we collaborate with them. We do a lot of work where we go to the Capitol and advocate for, you know, like 340B, you know, making sure that, like John Backus was mentioning earlier, you know, the governor was looking at having the health plans no longer manage the medications for clinics. So we do a lot of work advocating for things like that that are going to affect our health centers. And we also have the National Association for Health Centers in California, which is called NAC. And so we do a lot of work from LA to California to the national level. And what I'm going to be talking to you about is on a national level with collecting social determinants of health. So this is giving you an idea of the kind of patients that we serve and the amount of patients that we serve. And this isn't just for California, this is nationwide when it comes to the community clinics. And as you know, our focus is the homeless and uninsured, underinsured. This is a great diagram that NAC put together to kind of show the patients that we serve. So, and just to point out the ones that are really relevant to our discussion today, 13 million are in poverty. Well, to tell you the amount of patients, 28 million patients. Out of those patients, 13 million are in poverty, and 1.4 million are homeless patients. So think about that. That's a lot. So it's an issue that expands beyond LA County. And then on the bottom left, you'll see 82% are uninsured or publicly insured, and then 91% are low income. So these are the patients we're talking about there, and you'll see later in my slides that it really does affect their care. So the tool that we are using right now, and this is in collaboration with NAC, and it's called Prepare. And spelled with the A, not with the E, and after the R, and it stands for Protocol for Responding and Assessing Patients' Assets, Risks, and Experiences. Now, it's made up of 21 questions that basically are asking about the socioeconomic needs of these patients that are uninsured. And the concept is to collect actionable data that the health centers can actually do something about. For example, if we find out that they don't have a meal, giving them food stamps. So it's interesting because going back to what I mentioned earlier about watching this evolution of electronic health records, this tool started out on paper. And since then, it has moved into being integrated with the top electronic health records that are used in the community clinics, which is eClinicalWorks, Epic, GE Centricity, and NextGen. And it's been great working with the vendors. The vendors have been very responsive in helping us develop these tools so that our health centers can use them. That's another thing that we do at CCLAC. We have a user group for NextGen, a user group for eClinicalWorks, and we build a really strong relationship with the vendors in order to do this kind of work. Not to take any credit, this was all NAC. And so the measures that they collect align with Healthy People 2020, meaningful use, ICD-10, and UDS measures. Another great thing that has happened since I created these slides, is something I just found out about yesterday, is that now there's crystal reports that have been developed so that the data that's being collected around these patients can now be assessed. So an example would be, what's the proportion of high-risk patients that a community clinic has? And how many don't have money for their mortgage payment or for rent? And what the rate of utility needs for the patients. So the great thing is by taking an electronic health record, combining it with a tool like this, and I'll go on here to kind of show you the kind of questions that are asked in this tool, you're kind of creating this one-stop shop for patient care, which goes beyond the actual doctor's office. So, when a doctor has a no-show, there's a lot of reasons behind why that patient might not be there. So when you're going and you're asking these questions, you're reducing the cost for the clinic, because if you can address the reason why that patient couldn't make it, or the reason why that patient couldn't take their medication, if you can give them a food stamp because that medication requires, taking food, like a few months ago, I actually ended up getting a concussion, and I was on Norco, and I made the mistake of taking that with milk. Oh my God. And yes, so if someone doesn't have the food that they need to take a medication that they need to be taking, it can be detrimental. So these are the kind of information that's being collected. So personal characteristics. An example would be race, ethnicity. Are they a veteran? Family and home. Do you have a home? What neighborhood do you live in? Money and resources. What level of education do you have? What's your income? What's your transportation needs? Social and emotional health. How much stress do you have? Social integration, like how many people have you integrated with in the last couple months? So are you secluded? Are you, so things like that. Other measures would be refugee status, domestic violence. So there's a lot of different questions that are asked. And so this pilot that was done used this assessment. And there was 8 different organizations, including Community Clinic Association, and the logos for all the organizations that were a part of this pilot are around there. And it was funded by Blue Shield of California. There is 2,528 patients that were a part of the pilot. And the findings were that 43% of them did not have any material security, such as housing and food. So that's a lot. And that's just 2,525 patients. So imagine if you expanded that assessment. And it showed that the top 5 SDOH risk needs among these patients were their education level. They did not speak English, uninsured, lack of transportation, and unemployment. Now this was just a pilot, so this is something that we are now implementing widely among our community clinics. Now this really helps it sink in. This shows you that with patients how economic disadvantage affects their conditions. So this is showing you how much higher some of these conditions are if they are economically disadvantaged. So now NAC has created a national team where they are taking the data that has been collected in Prepare and creating risk stratifications. So basically what that means is, so here I'll just go ahead and read the definition. So risk stratification is an intentional, planned, and proactive process carried out at the practice level to effectively target clinic services to patients. And so the idea is that if you have the patients, you're collecting the data, there are certain patients that might have 4 or 5 disadvantages. And the more disadvantages they have, the higher risk score they are. So by doing that, you're basically, I know there's one health center that mentioned to me that they have a totally different workflow for those patients, where they are connecting them to services that are beyond the 4 walls, beyond what's happening in the clinic. And through that workflow, they're able to serve them a lot better than the regular workflow. Some of the goals are, to create a core national standardized risk stratification method, to test different stratification methods that are being used, and to develop national webinar publications on best practice and lessons learned. So we are a part of this learning collaborative with 8 different organizations, and the organizations are spanned across the nation in different states. And this collaborative is supposed to be ending September 23rd. So it's going to be interesting to kind of see how that spans out. And that is my presentation. Thank you.
Thank you, Aisha.
Hi, everybody. Hey, I just want to get a quick show of hands on who's in the room. And you might already know everybody, but I don't. Who here works with a technology company or vendor? Raise your hands. Good. Who might be part of a health system, a hospital system? Great. What about ambulatory clinic or medical group, or IPA? Little? Okay. Health plan? And then what about government, policymaker, et cetera? Okay, great. So it sounds like we have a really nice representation of technology innovators and vendors, and also quite a few health systems and hospitals here in the room. And the rest of you should have a loud voice because you'll need to mix your ideas in with everything else. And I'm just gonna make sure I know how to, oops. I'm going to take a slightly different lens on this question of data, disparities, and the roles of HIEs. We are a health information sharing network like Lanes, serving California. And just to put California and LA into perspective, this is a heat map of different metrics around access to care and outcomes. Red is not good, and light yellow is better. And you can barely see LA, but it's circled in black, and it is red. And I think this provides really important framing for our work together, and it shows that about 40% of LA residents don't get recommended care. So never mind adding in the various other things we care about, housing, homelessness issues, mental health, opioid use, just the basic services that folks need to stay healthy, pretty high rate of not getting those here in LA. And here I've actually, excuse me, I'm working with 2 systems here. These are actually the clinical sites for my colleague Aisha. And the focus and lens I want to bring to this conversation today is I feel like our job as HIEs is really serving the safety net effectively. These are the folks at the front lines of care. These are the folks trying to innovate around social determinants, trying to link with other services. They're doing the heavy-duty work of providing better care, closing those care gaps, and reducing disparities. And while I think we've heard from Aisha as well as David Ford that there's a lot of bright spots, right? There's EHR adoption, there's tools, there's innovation going on. I think we can all agree that compared to some other larger and better resourced peers, they don't have access to the IT budgets, to the expertise, and to the data they need to close those disparities. So the lens I want to bring here is that how can we better serve and partner with the safety net, especially around HIE efforts, so that they can do the job that they're doing well, but with more power and more superpowers. So just speaking from the perspective of Manifest MedEx as a health information network in the state, we view it as our job to help close that gap of data resources and tool resources so that the safety net providers, even the smallest clinic or practice, can have the power of a well-resourced health system. So it's sort of like bringing the magic of data and tools so that you can act like you are a large health system, being able to generate the insights that John Bacchus talked about from what can be the noise of data. So I'd just like to talk about the 3 strategies that we're helping with. The first is bringing together more data, and especially claims and clinical data, and I'll talk about that in a minute. The second, and this really mirrors, I think, what Ali was talking about, is giving a helping hand, especially to these practices and providers, including in the form of financial support. And third, bringing specific powerful tools to them that can help them turn the data into insights. So let's go through these. So last week, an organization in DC that's kind of a thought leader in the health IT space, EHI, put out their annual HIE survey. And the headline was that we're seeing a rapid movement of organizations like Lanes and Manifest MedEx towards integrating claims and clinical data. Why might that be? Well, I think it's because of the things we've been talking about. It's because that in a world of value-based care and population health, and I would include in that the ACOs and things of that nature, but also whole person care and health homes. In that world of taking a population-based perspective, you need both claims and clinical data. And I'll talk more about why that is. So imagine I was starting in a made-up county of, I don't know, Marcus. I was starting in HIE. And I went to all the providers and all the hospitals, and I said, come join this thing. It's going to be awesome. Let's have some community meetings. Let's get together. Everyone's like, that's such a good idea. Let's do it. But like the telephone when it first came out, when you can only call one other person, you don't have a network, it's a pretty lonely place to be. So one of the challenges with HIEs in general is creating network effects. We know how powerful Facebook is now with billions of members, but when they first started, it wasn't nearly as powerful. And if you create network effects one provider by provider, and we all know the challenges of connecting ambulatory providers in particular, that is a long haul. And I saw this when I led the HIE program at ONC, is many HIEs actually went bust before they got to the end of the haul. So getting hospitals on board is awesome because you get those ADT feeds and you can make value right away. But the business of connecting ambulatory is going to be a journey we're going to be on for a very long time. So claims, think about it. You know the full list of providers, you know all the filled meds, you know all the encounters, and you know all the procedures on day one of having that plan on board. So we still want to connect to all those ambulatory clinics. We want to provide them services, but you don't have to wait till everyone is on board to get value from the network. So in a world of HIE where we're going to have a lumpiness in people coming on board, the day we get those claims onboarded, we have critical and valuable information for millions of people. And so it's an incredible accelerator. I use the term, we say this, I previously did development work in Africa and Asia, and you talk about skipping the landline phase, right? Going straight to mobile. And so I think claims can be a way that HIEs can go straight to mobile. But nationwide, only 15% of HIEs have claims data for 5 million people or more. That's only half the residents of LA. So I'm glad to say Manifest MedEx, so we're a statewide organization representing all of California. So we're a little bit different than a model like Lanes that's more focused on one geography. I'm glad to say, and it has been, our CTO is not here today, but I will tell you that he probably has less hair than he did a year ago. But the good news is we now have health records, including claims and or clinical data for 17 million people. That's about That's almost half of the people in California. And so we are really excited about the progress we've made bringing on claims data. We have, actually now it's 6 participating health plans. We just added another plan. We're delivering 80,000 ADT notifications each month. We have about 400 participating organizations, including, it's probably more like 80 hospitals now. And so, you know, again, the value of a network is how big the network is and how multi-sided it is. We believe, based on the hospitals we have now in our network, probably represent about 20% of the discharges in LA. So not everybody, but those, again, those claims data are a really nice complement to the clinical data. This is particularly important when you think about patients with multiple chronic conditions. So imagine that little Marcus County HIE. It had 5 hospitals connected, but none of the ambulatory providers yet. So all of those insights into how many providers the patient had, what their patterns of care were really limited just to the hospital data. Can I go a little bit more since? I know we're trying to, oops, that's really not very visible. So I said, let me just quickly go through the 3 strategies we were talking about. The second strategy is financial support and helping hand. We are offering a special program now till the end of the month where hospitals that are interested in joining MX, we're actually going to front resources to them, not even wait for the CalHIPSO program. So $30,000 for signing up and another $30,000 for connecting an ADT by the end of the year. And lastly, turning what can be noise into signal. We are offering, and these are free for anyone joining, and in fact, our ambulatory providers don't pay any fees to join MX. 1, real-time notification alerts on a very robust platform. 2, a longitudinal patient record, MX Access, which combines claims and clinical data. Maybe I'll just end with this, and I'll be quick. We are really excited at the results we're starting to see. This is Dolores Green. She's the head of a physician-driven ACO in the Inland Empire. They use our tools to do incredibly amazing follow-up using care coordinators and home health workers. And they are starting to see dramatically improved results against the kinds of things ACOs care about and all of us care about. So almost 40% reduction in patients who are not seen within 7 days of discharge, 3% decrease in ER visits, 5% fewer ER visits leading to hospitalization. So HIE makes a difference, reduces costs, improves care, and can reduce the kinds of disparities we're seeing across California and in LA in particular. I'm gonna have to go. My son's graduating from college on Tuesday, but my colleague Brittany will be here for the rest of the day. So thanks so much.
Thank you, Claudia.